Have you ever become violently ill after eating out? You're pretty sure what it was that made you sick, and from that experience did your best to avoid smelling or tasting what you believe is the offending food item ever again. Research suggests this is a strong adaptive behavioural response, known as conditioned taste aversion. It was this concept of conditioned taste aversions that formed the basis of therapies designed to treat alcoholism by Voegelin and Lemire in the 1930s and 40s. Classical conditioning, or Pavlovian's theory, is the framework for which the therapy is delivered. In this case, the neutral stimulus, the alcohol, is paired with the unconditioned stimulus, an emetic, to produce a conditioned response that results in an aversion to alcohol. But does it? While Voegelin and Lemire reported positive clinical data, it was not until 1978 that Baker and Cannon conducted the first experimental research with humans. For this reason, their research paper, Taste Aversion Therapy with Alcoholics, Techniques and Evidence of a Conditioned Response, is particularly relevant, as it attempts to answer the question for the first time: does taste aversion therapy for alcoholism produce behavioural changes in alcoholics? Baker and Cannon's rationale was to conduct methodologically sound experiments on humans suffering from alcoholism. The results from this would enable them to establish whether the patients had acquired an aversive conditioned response to alcohol as a result of therapy. If a person associates taste and illness through taste aversion therapy, then they will develop a conditioned response that will have aversive effects on their taste and smell of alcohol. The participants were two male inpatients recruited through an alcohol treatment unit. Both men were between 28 and 29 years of age, and both of them had a long-term history of heavy drinking. Both men were fully informed volunteers, and the men were medically screened to ensure they were in suitable health for the experiment. Cannon and Baker recorded the men's psychophysiological responses to alcohol by measuring their heart rates and skin conductive responses. They also conducted taste tests to record their attitude to these beverages. During these taste tests, they allowed the participants to drink as much or as little as they liked of each beverage, and this was covertly recorded as a preconditioned consumption benchmark to which they could later refer. It is important to mention here that the men were also being tested in the same way for non-alcoholic beverages. As the patients would not be receiving taste aversion therapy for these beverages, this would later form a control baseline from which to gauge post-conditioning responses to alcohol. These psychophysiological tests and taste tests were conducted both prior to and after the taste aversion therapy. Taste aversion therapy consisted of 5 sessions scheduled 2 days apart. Patients were given a series of medications both orally and intravenously, which would induce vomiting and nausea. Immediately after the medication, the patients swallowed their favourite alcoholic beverage. This established a taste association between the alcohol and the imminent emesis, and shortly after this the patient drank and smelt a variety of alcoholic drinks. It is recorded that the patients regurgitated between 17 and 29 times during and after the session. Once the session was complete, the patients were given beer with a medication that prolonged the nausea, and they were also required to continue smelling alcohol. Follow-up interviews and booster conditioning sessions were held at regular intervals over the next 6 months, and a significant other was contacted to verify any reports obtained from the patient. Following the therapy, both patients recorded a much higher negative attitudinal and taste rating to alcohol. Conversely, both patients recorded significantly lower levels of alcohol consumption. Non-alcoholic baselines did not really change. Psychophysiological results did vary and have been attributed to possible habituation or extinction. While both patients did admit to relapsing in the follow-up period, they recorded their overall propensity to drink as greatly reduced. The results reveal the patient's behavioural and attitudinal responses to alcohol following the taste aversion therapy as significantly different from their responses prior. There is strong evidence to suggest a learned association between the taste and smell of alcohol and illness. The attitudinal tests also indicate that a negative cognitive association has also been made between the alcohol and illness, so that just the idea of alcohol is aversive. While results validate Cannon and Baker's hypothesis, it does not prove it. There are a variety of limitations associated with these experiments. The first, and possibly the most important, is that the aversion therapy was given in conjunction with a multimodal approach, which included counselling and education. This raises questions regarding the origin of the conditioned response to alcohol. Was it taste aversion therapy? Was it the counselling? Or was it these things combined that produced the change in behaviour to alcohol following treatment? While Cannon and Baker acknowledged the conservatively sized sample group, a larger sample group could have provided more robust results in favour of the hypothesis, or indeed the reverse. A larger sample group could have also provided a greater representation of the population. At the moment, the results tell us that a conditioned response is possible if you are a man in reasonable health aged around 30. A blind study would be ethically unsound, but the fact that participants knew why they were participating and were willing to participate suggests an intrinsic motivation. How much does personal motivation contribute to aversion? This leads to other concerns. While Baker and Cannon acknowledged that many possible events could have correlated with conditioning, such things as guilt expiation, placebo effect, and cognitive changes, they assert that unfortunately it was very difficult to employ any more tests or procedures to achieve a higher degree of experimental control. Again, a greater sample size could have assisted in eliminating some of the possible coincidences in results. Cannon and Baker do concede that rigorous research is required to further investigate the relationship between the taste aversion therapy and its possible effects on long-term drinking habits in alcoholics. Since this time, research in this area has been limited, with no clinical studies published since 1981. However, a similar treatment is used as part of a multimodal approach to address alcoholism at the Schick-Shadel Hospital in North America today.